my name is Dr. Stephen Williams. I just want to thank everyone for your kind attendance. This is one of the first BJUI webinar series, and today we're going to be discussing the Identify study. I'd like to invite our co-host, Dr. Viru Karsi Virfanathan, and he is our senior author of the paper, but NIHR academic clinical lecturer in urology at the University College London and BJUI section editor.
Hi, Stephen. How are you doing?
Doing very well, Vera.
So, thank you for having us. And, you know, this is a great opportunity for us to spread the word of science in a fun way while sticking to some of the original science. And we have a great panel today. And I want to tell you what this study is all about with a short video. And before we do that, I wanted to introduce our first author of the study. And what we wanted to do at the BJUI is enable the authors and the audience to be able to interact. So this is our chance here. So without further ado, I'd like to introduce Dr. Sinan Kaduri, who is first author of the Identify study. He's currently doing his PhD at the University of Aberdeen and has been spending many years on the Identify study. Welcome, Sinan.
Thank you very much.
So, Sinan, I'm going to share the video for the study, and then we'll give you an opportunity to give your perspective about things.
Cancers of the urinary tract are associated with significant morbidity and mortality, with variations in their global prevalence. Hematuria, or the presence of blood in urine, is usually the earliest symptom and is a known predictor of cancer, and prompts referral of patients to secondary care. Data on the prevalence is, however, limited to single centers and small populations. Given the geographical variation of urological cancers, there are less reliable estimates of prevalence. Thus, in a large multi-center international study called Identify, conducted by the British Urology Researchers in Surgical Training or the BURST Collaborative Group, researchers evaluated disease prevalence in 10,896 patients across 26 countries who were suspected of having urinary tract cancer, either bladder, upper tract urothelial, renal, or prostate cancer. Prevalence was adjusted using 4 predetermined risk factors, namely type of hematuria, visible hematuria or non-visible hematuria, age, sex, and smoking, as well as for geographical effect. Of the enrolled patients, 65.4% were referred with visible hematuria, 28.9% with non-visible hematuria, while 5.64% of patients had no hematuria. The overall prevalence of urinary tract cancers in those with any type of hematuria was 28.2%, bladder cancer being the most prevalent, followed by the less common upper tract urothelial, renal, and prostate cancers. Furthermore, overall occurrence of the cancer was higher in patients with visible hematuria compared to those with non-visible hematuria. Notably, irrespective of the type of hematuria, a larger proportion of patients with cancer were male, older in age, and had a history of smoking. Overall, these findings suggest that adjustment for geographical variation and risk factors provides a more accurate and robust measure of cancer prevalence in patients suspected of having urinary tract cancers. Being the largest study of its kind across an international population, this study paves the way for better patient risk stratification and informs clinical guidelines towards an effective diagnosis pathway and treatment of urological cancers.
So thank you for the introduction, Viru. I hope you all enjoyed the video. I'm really excited and honored to have this opportunity to share our thoughts on the results and importance of this study. I wanted to expand on some of the results and points made in the video that are commonly misconceived. Many readers are often quite shocked by the high cancer prevalence reported in our study when comparing to historical work such as in the Edwards and Cadra papers. And we've explained that adjustment had a huge part to play in this. And to show why, I'd like to explain why not adjusting can give such different results. So if we take hematuria, for example, if the ratio of visible hematuria to non-visible hematuria in a study differs, that will affect the total cancer prevalence, because obviously there's higher prevalence of cancers in patients with visible hematuria. The same applies with gender ratio, how many smokers there were in the study population, the age distribution of the population, and the location of the study, especially if that study is a single center or just within one country. To demonstrate this very point further, if you look at supplementary table 2 in our paper, which shows country-specific unadjusted cancer rates, for the UK, this was 10.2%. And this is more in keeping with what previously Edwards and Kadra have reported, and more recently Tan et al. In their DETECT cohort. The other point which directly follows from this is that adjustment for geographical effect also means that countries contributing more data, such as the UK, are then weighted appropriately. So all these factors account for the difference between the unadjusted and adjusted cancer prevalence. Some readers have falsely assumed that the prevalence is higher because we have become better and more efficient at investigating cancer. But this is not what's being implied by the results. It's just a more accurate reflection of cancer prevalence in an international cohort because of the methodology used.
Well, thank you, Sinan. And I think one thing that is my esteemed pleasure is to welcome Dr. Angie Smith, who is the Associate Professor as well as the Director of Urologic Oncology at the University of North Carolina. So welcome, Angie.
Thank you. Really appreciate being here.
Absolutely. And, one thing I'd like to, first off is what is unique about this study and how do the results differ from prior work?
Yeah, so I think Sinan hit on a very important point, and I think that's probably why he started this whole webinar off on that point. This is the largest international prospective study we have in the space of hematuria. And he talked about adjustment, so I'm not going to talk about that piece of it, although that is a unique and important part of this specific study. But I also am going to talk about the fact that we need large numbers to investigate things like hematuria. And, many of the things that we're looking for with hematuria, like upper tract urothelial, is actually pretty rare in prevalence. You cannot really get a good estimate whenever you're looking at these smaller single center studies that previously or what we use to investigate prevalence. Furthermore, we want to get a better sense of what these international rates are. So I think that's one very unique aspect of this study. Another is about their methodology. I mean, it was very robust methodology. If you look at their methods, they talk very much a priori of what they set ahead of time. One very important aspect is how they classified cancer. So in this paper, they were very specific about how they defined that a priori. And that's important because if you look at some of the prior studies, that's not as clear. And then a second aspect is all about selection. And I would say there's a couple things to think about with regard to selection. The first is that this was intended to reflect real pragmatic practice. And if you look at a lot of the studies that have investigated hematuria, there was selection because they were, for example, there are some studies looking at biomarkers for bladder cancer. Well, there's going to be inherent selection bias in that specific study. So that's one aspect. This was unbiased in the sense that this was supposed to reflect real life practice internationally. And then the second is that these patients were consecutive. Sometimes there's selection bias because there are specific patients selected for the study in and of itself. And in this case, all of these centers were instructed to enroll patients consecutively, basically. And so this is to ensure that we see, or we actually have a reflection of everyone seen in clinical practice. And then I guess in addition, we've talked a lot about visible hematuria and non-visible hematuria, but in this study, they also included a small group, but an important group that had no hematuria. And that reflects real life practice. In fact, I had clinic today and I had a patient who had imaging that showed something, but no actual hematuria. It's an important population because we're still going to likely take them for some kind of evaluation. And in this study, because it was pragmatic, because it was real life, and it was enrolling consecutive patients, we have a picture of that as well. So I think all of those things reflect a very unique perspective that we've lacked in prior literature.
Thank you, Angie. There's a really interesting insights, and I must say I do tend to agree with you, being the senior author of the paper. So thank you for saying that in an independent way without me having told you what to say. So we're in for a real treat now. So we're lucky enough to have Professor Maria Ribal, who is a urologist at Hospital Clínic de Barcelona and chair of the EAU guidelines panel. So who better to ask the question about what the guidelines currently say on this topic of the investigation of hematuria. And I'd really want to know, Maria, what you think about how the guidelines might be influenced by this work.
Thank you very much, Veru. Good evening. It's my pleasure to be here. So thank you very much for inviting me. And well, what is in the guidelines? The truth is that in the guidelines, we don't have a proper flowchart on how to investigate hematuria. And probably you can think, well, how could this happen? And the truth is that it's really hard to find a clear consensus on how to evaluate hematuria. And we need to build proper models to do it. So what do we have in the guidelines? In the guidelines, we have, obviously, hematuria is the main symptom of, for example, bladder cancer or other cancers, and how do you should investigate. So, for example, in a bladder cancer, we have that for the workshop. In hematuria, you need to do a flexible cystoscopy, or that, for example, you need to add a CT urography. Once you have diagnosed a bladder cancer, depending on where it's located, just to rule out the presence of upper urinary tract tumors. So the truth is that in our guidelines, what do we have is which is the strength of the recommendation for performing certain studies in a circumstance that you have an hematuria. But this has been an issue that we have been really worried about, and we have been working on that for a long time, trying to work together all the panels, the renal cancer panel, muscle invasive, non-muscle invasive, upper urinary tract. And the truth is that we should take into account that hematuria is not only a sign of cancer. So there would be other circumstances that could also lead to an hematuria. So that probably should be taken into account. But it's true that the main diagnosis that worry the most is cancer. So what are we doing in the guidelines? What do we need to create a proper flowchart to give recommendations on how to study hematuria? So we need probably three things. The first is to know the prevalence of the disease. And it's for that a study like Identify is really, really important, because it gives us data about the prevalence, and also give us data on something really important, that is to adjust this prevalence, taking into account several risk factors. So probably this is the main thing we need. So what are we doing at the guidelines? We are doing a systematic review. It's a joint venture with McMaster University. You know that the McMaster University in Canada is the birthplace of the evidence-based medicine, and also with Cochrane. And the review is already was registered on Prospero, and it will be published soon, and Identify as in. So we try to merge all the data to understand which is the final prevalence of bladder cancer, upper urinary tract cancer, renal cancer in the population with hematuria, and also to stratify, taking into account several risk factors, as you already have done, considering the age, gender, smoking status, etc. But the truth is that also this is the most important data we know, or we need. There's other data that we also need to be able to finally provide a flowchart on how to study hematuria. And which are the two things you need also? You need the accuracy of the tests. So it's important to know which is the accuracy of every single test to detect a specific disease in a specific circumstances. So what does it mean? For example, if I have a visible hematuria in a men over 50 and smoker, the most accurate test I can do is a flexible cystoscopy, because flexible cystoscopy is the one that has the higher accuracy for detecting bladder cancer. So you need to put all together the prevalence, the test accuracy, and finally, which is the other thing you need to take into account, is the expectations of the patients. Because, for example, it has been demonstrated on patients that only with 1% chance of having cancer, they are willing to be submitted to explorations. So we need to build all of this, and we are working on that.
Thank you, Maria. I think you made some really critical points. I'm really glad that Identify made the systematic review, and we look forward to watching the guidelines closely soon. You'll be pleased to know there is a paper that will be looking at the diagnostic accuracy of the tests in Identify, which hopefully will inform that work. And just before I hand over to Stephen, I might ask the audience, if you have any questions whatsoever, put them in the Q&A section, and we will address those towards the end of the webinar.
Yes, that was an excellent summary, Maria. However, this leads us into a segue, Viru. Should we investigate all patients with hematuria then?
So quite a controversial question. I think hematuria means many different things. And clearly there's a difference between visible and non-visible hematuria and the risk of a patient having a urinary tract cancer. And there will be some patients, regardless of what we've said in Identify, who will always need investigation with cystoscopy and upper tract imaging. However, I think the point to make is really that there's a spectrum of risk for any patient. And there are a number of factors beyond the type of hematuria to give a patient's risk. And it's possible, for example, for someone to have visible hematuria and still have a low risk of urinary tract cancer. Now, specifically from Identify, no patients under the age of 35 with non-visible hematuria had bladder cancer. In addition, no patients under the age of 60 with non-visible hematuria had upper tract cancer. So this might influence a person's decision to avoid investigation altogether in that first group, and maybe avoid upper tract imaging in the second group. I think from a more holistic point of view, we need to think about patients, and Maria made the good point about patients. In addition, we need to think about the health economics. And as clinicians, I think we have a responsibility to reduce this massive problem of over-investigation. I think investigations and the patients who have been involved in our patient focus group work have told us investigations can cause discomfort and be distressing. They don't like investigation if they don't need it. So I'll challenge the audience, and I'm going to say to them to be sensible about who we investigate. Think about the studies such as the Halpern study in JAMA a few years ago, which shows that CTing everyone with non-visible hematuria has a massive cost. It's costing millions of dollars every year with very little benefit, and if anything, can cause more harm from causing secondary malignancies. So I think overall, we've really got to change our mindset and get thinking, and hopefully Identify will set people off and help us to do that.
Excellent summary. And Dr. Smith, do you have anything else to add to this?
Yeah, I think this is, Viru hit it spot on. I couldn't have said it better. You know, there's always a place to begin. And as a provider, and practicing in the United States, there's always the concern for litigation, medical, legal implications of what we choose. And I tend to believe there is this, and you can see it in active surveillance for prostate cancer, you can see it in any kind of urologic or medical decision we make, where we have a bias toward more and more diagnosis and more treatment and more, because that is, that's going to be better. But we tend not to reflect on the drawbacks of all of the interventions that lead up to that. And I think this paper is that is to me the big take home. I will say, for years in practice, I felt uncomfortable getting CT scans in young women with asymptomatic microscopic hematuria. I'm almost certain that they're not going to have it. And now I have a paper now to support that. Now, I had sort of been rolling that out, but the provider, first and foremost, have to be very comfortable in how they address it with the patient, because the patient is watching you, they're observing you, they're using the words that you choose. And based upon all of those things, they're going to either feel comfortable about taking a step back and saying everything's fine, or they're going to feel anxious and want to have another procedure. So I always say it starts with you, and you have to get your thoughts straight. I think this paper is really helpful because now we have some evidence to support the fact that we are probably over surveying, right? You can see, less than 35, less than 60, no upper tract, less than 35, non-visible hematuria, no cancer. So we can at least start there and build upon it. And we're seeing some of that in the guidelines, changes for the AUA, et cetera. But I couldn't agree more. It's just nice now to have some evidence to get providers to feel more confident when they counsel patients.
Yeah, excellent. It's such a pivotal time, right? So exciting now. We're not saying one size fits all, and that we could actually tailor these. And we have a study that actually has helped elucidate this. So this brings us to the next discussion, Dr. Kaduri. The group of patients without hematuria was indeed interesting, as they had, very high cancer prevalence. And why were they referred, and what can we learn from this actual specific group?
Yeah, so as Dr. Smith was saying, this group of patients really made the study quite unique in that it reflected a more pragmatic reflection on the patients we see. So the reasons for referral of patients without hematuria are listed in the supplementary tables, table 4. Briefly, however, over 50% of patients were referred with an abnormality found in imaging, 31% with lower urinary tract symptoms, and the remaining were a mixture of recurrent UTIs and other reasons such as hematospermia, spotting, or abnormal cytology. Of course, there were some patients that had more than one reason, so the reasons overlapped, such as a patient would be referred both with abnormal imaging and lower tract symptoms. But if we take these three main groups, these three stratified groups, so the abnormal imaging, the lower urinary tract symptoms, and the recurrent UTIs, and look at the cancer prevalence within each of them, it helps to explain the high total cancer prevalence of 33% in patients without hematuria. And as you'd expect, the majority of cancers were in the group of patients referred with abnormal imaging. Actually, half of those patients were found to have bladder cancer. However, the prevalence of bladder cancer in patients with lower urinary tract symptoms or recurrent UTIs alone was 10%. Now, an interesting way to look at that is that's almost double the bladder cancer prevalence within the non-visible hematuria group. Now, I'm not implying that patients with lower urinary tract symptoms or recurrent UTIs have a higher rate of cancer than those with non-visible hematuria, because essentially this is secondary care data. And we must remember that patients without hematuria are being assessed in primary care. So there is a high possibility that the patients being referred without hematuria but suspected cancer are as a result of good triage and clinical acumen in primary care. This is certainly a group, though, that requires further analysis to fill in the gaps in evidence regarding these patients. And we hope to do this in future publications from the Identify study.
Thank you for elucidating that group. And Dr. Ribal, do you have anything further to add?
No, I think that Sinan has done a great summary. I just only want to point out something that is important. This is obviously not a very large group, but I think that there are two important messages. One, if we, for any reason, do an image, I don't know, abdominal pain, whatever, and then we find a suspicious image of bladder cancer, this should be directly further investigated. And the second is that obviously that not every single infection should be studied as a bladder cancer, but the most important point for delaying the diagnosis of bladder cancer in women worldwide is because they are treated as a recurrent infection or urinary symptoms. So please, sometimes we should put and pay attention about age, risk factors, etc. in these circumstances. These are my only comments.
Very well put. So this brings us to another discussion, and particularly Dr. Karsivifanathan. How do we practically use these results in our daily practice?
Thanks, Stephen. So I think what we've learned from the discussion so far, as you said in your own words, is that one size doesn't fit all for hematuria investigations. And so what we've tried to do as a group is to make applying the results from this study to your patients as easy as possible. So if people talk about take-home points from listening to talks, and a lot of you have spent some time coming to this webinar, if there's one thing I want you to do after this webinar, depending on what time zone you're in, maybe tomorrow, if you're in Europe, is to have your patient who's sitting in front of you or a referral that you're receiving with suspected urinary tract cancer, go to our website, www.bursturology.com. We have a risk calculator there. You enter your patient's basic details, which literally takes 1 minute. You'll specify their age, gender, type of hematuria, smoking status, and so on. And that will give you their exact risk of them having urinary tract cancer based on the Identify study. And I think the key point is that that figure will help an informed discussion between you and the patient. You may decide, for example, not to investigate them at all if the risk is very low, or if you do investigate them, it may influence how urgently you do that and what modalities you use to investigate them with. And I think on a service level for your hospital, it will help you run your service and allocate your resources appropriately. Going one step further, I think these results provide the evidence that may enable us to alter the sequences and pathways by which one chooses to investigate suspected urinary tract cancer. And hopefully we'll get a chance to elaborate on that later on in the discussion.
Yes, and thank you for bringing to our attention that risk calculator, so useful. But Dr. Smith, what are your thoughts in regards to utilizing these data in your daily practice? You pointed out earlier, but would love to hear your thoughts.
Yeah, I had mentioned just very briefly that the new AUA guidelines for microscopic hematuria are really helpful. And reflecting this study, the Identify study, and the way that the guidelines were created a risk stratification schema, they actually do reflect very well the Identify risk factors that were noted. So basically there's low, intermediate, high risk. And, I like how simple it is. It's pretty straightforward. If they're younger, that tends to be a more low risk situation. If there's visible hematuria, a high risk situation. If you have a smoking history, again, high risk, but it's stratified based on number of pack years, current smoking status, etc. So I have been using that. It's helpful to have the Identify results as well as some guidelines to reference. And I've been using it very regularly now. As I mentioned, over time, my practice has shifted where I have been downgrading the amount that I've been doing for some of these. So if I have a very young patient, no risk factors, I might even repeat a urinalysis in 6 months and do nothing at all. Letting them know what the risks are, showing them some data. Having a risk calculator is even more helpful, especially for those patients really interested in understanding of risk. Sometimes it's hard I found it sometimes difficult to explain risk in a way that's very understandable. And that's something I'm continually trying to improve upon. But yeah, in my practice, I've really downgraded the amount of surveillance that I do for this, especially for the lower risk categories. That being said, just like any guidelines, when you're trying to make them simple, it certainly is not perfect. And Viryo said this a little earlier, not all visible hematuria is high risk. That's probably true, but I think we need to have more evidence to know exactly who those patients are before we know exactly what to do and say, you don't need any kind of surveillance for this visible hematuria. I don't feel like we're there yet, or at least I feel like we need a little more evidence to suggest who is that patient where you really don't need to do anything with visible hematuria.
It's an excellent summary. One of the things that, is critical, Dr. Kaduri, what alternative pathways might exist for investigative hematuria?
So I think a lot of the points have been mentioned already. I think at the very least, we can learn from some of the cancer prevalence data, especially the tables in the paper showing cancer prevalence stratified by visible and non-visible hematuria. So it can be a bit of a lookup table for you, if you like. And we've already talked about, for example, the non-visible hematuria group under 60s, that there was no upper tract urothelial cancer, but you can look at the 70-year-old group and see what the prevalence was there. And then you can make an informed decision about, whether performing a CT urogram in someone aged 70 or 60 with non-visible hematuria is potentially more harmful than beneficial. Essentially, though, just to mirror what everyone's been saying, I think we want to move towards a more personalized care and investigation of the patient. On top of that, we want to use our resources efficiently. So again, one suggestion for this is to have the risk calculator or the tool, be it the Identify Risk Calculator or the AUA stratification tool, that then risk stratifies the patient. But on top of that, like Dr. Ribal was saying, you need to have a suggested investigation that follows on from that, that's performed as a result of the risk category. So an idea might be to have a very low risk group who do not need any investigation at all, a low risk group who has the least invasive investigation, perhaps just an ultrasound only, but proceed with a cystoscopy if the bladder wasn't visualized adequately. Then in your intermediate risk group, perhaps they could have a cystoscopy and an ultrasound. And in the high risk group, have a CT urogram up front, followed by a flexible cystoscopy, or even straight to a TURBT if a tumor is found on CT. I think it's all good and well talking about risk stratification, but the key behind this and any stratification system is the threshold people would be happy with for these risk groups. So for example, in the very low risk group where you're thinking about not investigating anyone, can you say we shouldn't investigate them if they have a risk score less than 1%, because actually doing a cystoscopy has a higher risk of infection? That's one way to look at it. So it would actually be great to see what the audience's opinion is on what these risk thresholds are. And I believe after this webinar closes, the BJUI will open a Twitter poll where you can make your opinions known. So please vote, because we're anxious to hear about it.
Excellent summary. Yes, and please enter your Q&A, any questions you have down below. And Dr. Ribal, do you have anything further to add in regard to our risk stratification and pathways? But this is very exciting work.
No, I think that everything has been already said. If we were able to build these clear pathways, it will be marvelous. I think that we are forgetting for a bit something that I think that I don't know when in the future will be incorporated to these pathways. That would be the markers. So I think that molecular markers will be at some moment. I don't know. I've been in this for more than 20 years, and I'm always saying the molecular markers are here, and now it's not the future, it's now the moment. And look, 20 years after, still I'm saying probably in the future we can incorporate these markers, but just open a window that perhaps in the future molecular markers could be even in these pathways. We will see.
This, presents us now into our open, questions, from our webinar attendees. And I want to thank everyone for your time. And I'm going to hand this over to Viru.
Thanks, Stephen. So, guys, this is your opportunity to interact with the authors. Questions can come in now if you want, and in the meantime, we'll start asking some. So I've got a really nice controversial question from Alistair Lamb. So I'm going to actually get each of your opinions on this. So Alistair Lamb has asked, is there a general agreement now that we don't need to investigate non-visible hematuria? Does this apply to all patients or just young patients? So maybe first I'll go to Angie.
Great question. I'll just speak for my own practice. I don't think I am comfortable yet to say no patient with non-visible hematuria needs a workup. Because the Identify study, there are still some cancers, the prevalence is lower, but they still exist. And certainly we've seen in our practice, my practice is almost exclusively bladder cancer. Many are picked up with non-visible hematuria. Now, many of those have other risk factors. So I do factor that in. I would just amend that I wouldn't say all, but I do think that the low risk category, probably young patients, no smoking history, don't need a cystoscopy. And then in terms of upper tract imaging, I would take that a little bit more. So perhaps these upper tract urothelials who have very low risk factors, or even just less than 60 years old, if you want anything, maybe an ultrasound, but no, I don't generally do CT scans. So I think for cystoscopy, I can't in my practice, I don't just say all patients don't have cystoscopy. I'm not there yet. I feel like we need more evidence before I can make that next step.
Thanks, Angie. And I'm going to ask the same question to Sinan.
Yeah, I think one of the best ways potentially to think about visible and non-visible hematuria is potentially a spectrum. So rather than treating them as a binary variable, think about them as, okay, this patient has non-visible hematuria. Maybe in a few years' time, as the cancer develops, it will become visible hematuria. So you have to, very much as Dr. Smith was saying, take into account the other risk factors that will increase that patient's risk of cancer, especially bladder cancer. Using something like a risk calculator can really help with that, because you can have a patient in front of you with lots of risk markers, but non-visible hematuria, and their risk is higher than a younger patient with a UTI and a visible hematuria. So that's how I would think about it.
So I think in summary, the consensus, Alistair, was no, not everyone. Use our risk calculator, combine it with the other risk factors, and you'll get your answer.
Very well put, Viru. So I'll take the next question. This comes straight from the top. So this is from Dr. Freddie Hamby. This is a terrific debate, but what is the next piece of research that is really needed, if any, to consolidate evidence to manage these patients and change guidelines globally? And where are we with urinary markers? So I'm going to hand this over to you, Maria. What are your thoughts?
Well, I can start by the second. Where are we in urinary markers? Yeah. Honestly, I don't know how to answer you, Fred. Thank you for the question. But the truth is that we have markers that have been studied, and where do they seem that could help us? Probably in the follow-up once we have a diagnosis of bladder cancer. So in this setting, it seems that molecular markers could be helpful, but we are not talking about this setting. We are talking about a setting that it's quite more complicated. That is the screening or the primary diagnosis. So what do we need? A perfect combination of sensitivity, specificity, etc. And the prevalence of the disease should be enough to understand that we should to use these markers. It has been said, for example, why we don't use it in a very specific population, smokers over 50, etc., with all the risk factors. But the truth is that those that are really good in the follow-up because of a good sensitivity and specificity that sometimes reach the level of the cytology, although not all of them, and not at the level of the cytology, because we have a very good marker that is cytology. I think that by the moment we are not prepared for using them in the routine practice, but as I have been said for 20 years, I do really hope that in the near future, we will use them.
Excellent. And I guess, Angie, do you have anything else to add to that? Particularly also too, I know we are, you and I, with health services research, taking these data and try to understand how we can apply these. We have the risk stratification, but what further research now is needed for implementation, dissemination, and particularly maybe value care and cost of care?
Well, sure. I mean, I think all of the above, right? There's cost effectiveness analyses that could be incredibly useful in this regard. I mean, this is ripe for that. I also think that with regard to dissemination and implementation, I think we're maybe a little, you're not necessarily early for that, but I think we have to get a sense of like the algorithm that we choose to use. Maybe it's the AUA guidelines, risk stratification, EAU is developing theirs, but having some kind of algorithm and then trying to disseminate, implement that and study how that's going to be done, because that's going to be a challenge. But I also am interested in Sinan's thought. He had his hands raised. I know that he's been thinking about this as the lead author of this study. I'm sure you put a lot of thought into your next steps.
Yeah, I think I just wanted to echo a lot of what Dr. Ribal said, in that you need these components to build your diagnostic pathway. So yes, you have the prevalence data, but then you need the risk stratification system, whatever that is, followed by the test accuracies to then assign to each level of risk. And once you have that pathway, I think realistically, you're going to probably need to do some sort of trial, a non-inferiority trial, but also build into that health economics to show that the new diagnostic pathway doesn't miss any more cancers, is a better use of resources, and saves money as well. I think that would probably be the final evidence that's needed to show everyone that's the way to go.
And I assume that this is in the works then.
So from the Identify study, there will be the risk stratification publication to come, and the diagnostic accuracies, which will hopefully build the pathway. The trial, who knows?
We believe in you.
Thanks, Sinan and Angie. So we have another question from the audience from Atif Khan. And this is going to be to Angie, because she made a comment on this earlier. So he said, we send a lot of patients for upper tract imaging to detect only 1.1% of upper tract disease. What's the pragmatic way to go ahead?
Yeah, so in my practice, anyone who has low and even intermediate risk, I either don't get any imaging at all, or I might get an ultrasound at best. I think an ultrasound has very minimal risk. It's cheap, it's easy to perform. And I think you're going to find, if you're gonna, it might not be the perfect test, but you're gonna detect something that, you're not gonna miss a big cancer, or you're not gonna, you're gonna see something, and maybe it's hydro, maybe it's just like a mass, and then maybe you get the CT scan. But in general, I don't use upper tract anymore. Now, if I have a patient with risk factors, visible hematuria, and who is older, I do, for those patients, get a CT urogram in those, only because I know their risk is higher. But it's very few and far between that I get CT urograms anymore for non-visible hematuria. And even for visible hematuria, I try to reserve that for the higher risk patients. But I always have the discussion. So I'm always talking to the patient about this. And that's what kind of goes back to what I had said before. You have to be really solid in what you believe so that you give a good pitch to the patient so that they trust what you're saying and they make a good decision based upon not your bias or your fear of missing a cancer, but rather what the data are showing you and what you think is best for them.
So I think this leads me on to two questions. One is going to be for Sinan and one is going to be for Maria. So Sinan, do you want to give a sneak peek of how ultrasound performed for the upper tract cancer diagnosis compared to CT urogram?
So off the top of my head, you put me on the spot, but ultrasound was not as sensitive as CT in detecting upper tract urothelial cancer, and I think that's known. That doesn't come as a surprise. It was, however, more sensitive at detecting bladder cancers than CT, more interestingly. And if you ask radiologists, they'll agree with that and find the logic in that. However, the most important thing I think was the specificity between ultrasound and CT was very, very similar. So it was something like 98–99%. So, you know, patients are more interested in specificity, doctors are more interested in sensitivity. So that's what I would say. And I think ultrasound is a good tool, at least for example, an intermediate risk patient to begin an investigation.
Thanks, Sinan. So we've got a really interesting comment from Andrew Dickinson, which will lead into a question for Maria. So Andrew Dickinson was one of the authors of the original Edwards paper. So thank you for listening, Andrew. It's great to have you and your expertise here. And he's very happy with the data we've produced. And he suggested we just need to trust the data and not over-investigate. So Maria, the EAU guidelines panel are doing a lot of work on implementation of guidelines. Can I ask you what you think the main barriers are to changing practice and reducing this over-investigation we've highlighted?
Wow. Well, the truth is that this is the $1 million question. It's true that we are working so much from the EAU guidelines on to understand, because it's not only important to disseminate. For example, EAU guidelines are endorsed by 75 urological societies. So it's worldwide used, and we are happy for that. But this doesn't mean that people is using really our guidelines. For example, we have had a lot of publications saying, for example, in this country, the strong recommendation of performing an immediate installation in bladder cancer is not followed, or the use of androgen deprivation in prostate cancer is more, prior to radical prostatectomy, is more than X% when it should be known, 0. So the truth is that the implementation of the guidelines is something that we are now working for the last 3 years. We have a project that it's called Imagine, and we are testing with national societies and working with several hospitals around the different countries in Europe and different types of hospitals. We are testing some of our recommendations, and we are recruiting data on how these recommendations are being applied in the different type of hospitals, academical, small ones, private, in different countries. So we will have this information. In fact, we already have information about the use of neoadjuvant hormone therapy prior radical prostatectomy, and we will communicate during our next EAU 22. And which is the second step? Once you know how your recommendations are being implemented, the next that you should do is a second step study, just to understand why those recommendations are not being followed or why they are really well followed. So you need to structure good surveys to understand with national societies, key opinion leaders, local representatives, which are the barriers, because the barriers are several. Sometimes it's a healthcare issue, government's issue, local disponibility of the things. We are saying that the robotic is great and robot is not everywhere. We are saying that this drug is marvelous and this drug is not available everywhere. We are saying this drug is perfect and perhaps it's not accepted in every single country. So there are a lot of barriers that should be taken into account. But the truth is that the only and the main reason for existing for the guidelines is that they are already implemented. It's the only way that we can ensure that we are practicing the best way for our patients.
That brings us to, can you believe it, already an hour almost has come up, you know, such a great discussion. You know, I personally want to thank, you know, our panel, but also to our guests that have attended, you know, such a wonderful discussion. And Vera, do you have anything else to add? I know we have our Twitter is open, so if anyone has some questions that didn't have a chance to post them, please do so.
Thanks, Stephen. I wanted to echo your thoughts. Thank you, everyone, for attending the webinar. Thank you to our expert panelists and to the BJUI for this unique way, really, of portraying the science in an exciting and engaging way. And I hope you've enjoyed the discussion. I'd like to thank the funders of the study and also the patients who took part and all of the collaborators who contributed data to make this collaborative effort, which is a new way of doing research, work, and without whom we wouldn't have a study to talk about. So I'd like to encourage you all to go onto Twitter for 48 hours only. You can ask any questions you want, and one of the authors and some of the BJUI editorial board members will be around to address those. So let's get some active discussion going, and thank you very much for attending.